Thank you, Dr. Abu Samra. This was a very nice overview about a rather common entity we encounter in our practice. And now we have question for both of you. I'm not sure if now Dr. Muna is with us, Dr. Fudda. We have like 7 minutes for questions and answers.
Yes, hello, Dr. Sam.
Yes, okay, welcome, Dr. Fudda.
Thank you.
I wanted to comment, Dr. Can I?
Yes, sure.
Yeah. So I want to comment on the concept of, normocalcemic hyperparathyroidism. In cases that I seen here in Middle East, I haven't seen in the US, and these are chronic vitamin D deficiency that manifest, I believe, with lack of vitamin D for a long time would cause hyperplasia of the parathyroid gland. And when you replace vitamin D, it takes very long time for PTH to normalize. And you will see during this course, maybe lasting 6 months to a year, you find people with normal vitamin D, normal calcium, and PTH still high. And you may conclude this is normocalcemic. But if you stay, if you maintain and continue, you will find in a year or later, PTH come down. I've seen that with multiple cases, and I think this should be considered before we jump to the conclusion might be normocalcemic. And when vitamin D deficiency is chronic and has been there for a long time, we have low bone density, mostly from loss of calcium, but we have osteomyelitic bone. And when you treat them with vitamin D, actually the bone density doesn't get better, it gets worse for a while, and then pick up after 3 to 6 months later. That's also, it gives the bad impressions that we may have a disease with impact on bone. So I think we need to consider that specifically in this region. Okay.
I totally agree with you. Especially in our area with, very common vitamin D deficiency, we shouldn't jump. And they emphasize that in all the meetings, that vitamin D deficiency should be ruled out. Yeah, and I agree with you. In our area, maybe it will take longer to normalize before we can say it wasn't vitamin D deficiency. I agree with you.
Dr. Fudda, I have a question. Do you end up measuring 125 dihydroxyvitamin D in those patients who have normal vitamin D and you're suspecting a deficiency in the active form of vitamin D to explain this normocalcemic hyperpara? I don't see it in any of the algorithms myself, but you mentioned...
No, they never mentioned that. They actually mentioned that maybe we should measure the free unbound 25 vitamin D, not the bound, that the one we usually do. So it's the free unbound that might be related to this PTH level, but not the 125, not the active one.
How easy is it? Is it available?
No, it's in most centers it's not. I think maybe it's just mainly for research purposes and very specialized centers. Yeah.
And I should mention that I've encountered many patients who were really extensively studied, and they were on bisphosphonate or even denosumab, and with a mildly elevated PTH. And obviously they have osteoporosis, and they are treated, and now they have this entity, normocalcemic hyperpara, and because of osteoporosis, they get further workup. It's like a vicious
circle. Like a vicious cycle. Yeah. That's why in the latest guidelines,
the history of medication intake.
Yeah, exactly. And that's why I pointed in the latest algorithm that came from the American Endocrine Society, the long list of medications. It's a very long list, including denosumab and bisphosphonate. So we have to make sure, that we've ruled out all those factors before
How do you rule it out if it's due to the bisphosphonate or it's really normal calcemic hyperpara? With the denosumab, you cannot stop it to. I mean, and same for the bisphosphonate. So you end up
I
leaving.
totally agree with you. Those people are presenting with end organ involvement, with osteoporosis or with renal. So it's a conundrum. Yes, it might be difficult.
Sure.
And the audience, do we have questions?
Yes.
I have. Go ahead.
Yeah, this is a question for Dr. Abu Samra. And in our center in Riyadh, we have an epidemic of high PTH, and we've done a lot of strategy to see if we can bring it down. For example, pushing the vitamin D level from the lower limit of 70 to 100 with some success, measuring the urine calcium and give people calcium to see if this will correct it. But for the most part, you cannot explain it. And we called the lab, and their explanation was, a biochemist in the lab, was if you don't analyze a sample within certain time, I don't know this time, and this is a Roche assay, the PTH level actually goes up. And we've seen it in a few people that you can actually drop the PTH by 50% if you take the sample quickly and analyze it. Have you come across this, and do you have an explanation for that?
Well,
I don't know if
I don't have explanation. I would predict the reverse. A PTH half-life in serum and in the blood is very short, like 15 minutes, and will disappear quickly if you don't, process the blood sample quickly. So I would expect longer you keep, less PTH you find, not more. But I'm not sure unless this specific assay has something special.
Yeah, this is against what we've learned, that hormones just goes down very quickly. If you, but in this particular instance, PTH assay actually gives you a falsely high values if you don't analyze it, and this is a Roche assay.
Yeah, well, I'll look. I don't know that. For regarding 125 measurements that came up, we should never measure 125 unless we are doing differential diagnosis of hypercalcemia and PTH is suppressed. That's the only indication when you do 125. And so in normal calcemic, no point of measuring 125, I agree, or in any other thing. If we're looking for vitamin D deficiency, we measure 25 hydroxy D.
I have a question from the audience. There was a question. The time of teriparatide is limited to 2 years. What do you do? This is when you were using teriparatide for the hypopara, and they said you can't give it beyond 2 years. So the question is, what do you do after that?
So the 2 year is for osteoporosis originally, and for osteoporosis the reason is because after 2 years, bone mass maximize, you don't gain much. So the idea is do 2 years and follow up with anti-resorptive to maintain the bone mass. If you continue with teriparatide, you're only spending money without effect and you may accumulate harm. So that's the rationale. For hypoparathyroidism, there are data up to 3 years and data up to 5 years. And they don't talk about effect, because the objective there is to maintain calcium and phosphate within the normal range, not talking about bone density. And so the 2 years criteria doesn't apply.
May I ask you about the use of cinacalcet in primary hyperpara in your practice, both in those people who refuse surgery? And so what's your experience with that? And you keep them indefinitely on this treatment? And what's the course of the treatment? You add those would increase over time, and how far can you push this treatment?
Typically in the primary hyperpara, which are simple, meaning not like this case, you probably need 30 milligram TID, and you will be fine for a very long time. The cinacalcet will normalize PTH and will normalize calcium. but I'm sorry, will normalize calcium. PTH remain a little bit high, and the effect on the bone is not protected, and therefore you may need to add an anti-resorptive to protect the bone.
So what's bad with that?
Sorry? My-
Why isn't that an option as a, it can be as a first line in lieu of surgery?
So I'm sorry. So that the trial with cinacalcet and primary hyperpara published, it's showing normalization of calcium. It's showing PTH came down but remain in the upper limit of normal, and showing it did not suppress bone resorption, and that's why that's the recommendation. But were published by a couple of papers in GCM on that.
Okay, and the audience, any questions? If not, I think we're past our time, and I thank you all for attending this beautiful symposium. And I would like to thank Dr. Abu Samra and Dr. Fudda for the beautiful, very comprehensive lectures. And if you would like to, one of the questions in the audience from the audience said that maybe if they have questions for you later on, they may send them to you to answer them tomorrow or later on. I don't know how, but this is we can share your contact with the people in the audience. And thank you all for attending this seminar. Thanks.
Thank
Good
you.
night.